Next case scenario, I've been stabbed. This is a case of an 18-year-old man who was brought to the emergency department by the paramedics after being stabbed with an ice pick on the right side of his back, just left of the scapula. He complains of right-sided chest pain with inspiration and shortness of breath. No other injuries occurred. The patient is otherwise healthy. Tetanus immunization is up to date. He is healthy appearing male in moderate distress. Vital signs are blood pressure 120/70, pulse of 110, and respirations of 25. His head and neck are without any evidence of injury. There is no jugular venous distension or crepitus. His heart is normal without murmurs or muffling of heart sounds. Auscultation of the chest shows diminished breath sounds on the right side, but the left sounds normal. His abdomen is soft and non-tender. On his back, there is a 1 centimeter laceration just medial to the right scapula. There is no active bleeding or hematoma. There is no crepitation. What do you think that is? A penetrating trauma to the chest. This patient has absence of breath sounds on the right hemithorax after being attacked by an ice pick to his right hemithorax. The protocol for managing this patient in the emergency room after arrival is what? Remember, primary survey followed by secondary survey. Primary survey is A, B, and C, D, and E, which means airway, breathing, circulation, exposure, and disability. Okay? You have to make sure that during your primary survey you identify life-threatening conditions before you move on to next. Now, this patient appears to be quite comfortable as you are doing the primary survey. While examining him, you notice that the patient's blood pressure suddenly drops to 60/20. His respiratory rate goes up, and so does his pulse rate going up to 150. Patient has distended neck veins and forehead veins. His trachea is not deviated. His right chest has absence of breath sounds. However, he does not have any significant resonance on percussion. What is the next appropriate step in the management of this patient's condition? Needle where? A needle was inserted into the right mid-clavicular line, and no air was found to have relieved from this patient's chest wall. His cardiovascular compromise proceeds, and he continues to go from bad to worse. That's right. You have to think about cardiogenic shock in 3 ways. I mean, this is easy stuff. You all have to know this. They love cardiogenic shock in trauma. And there are 3 reasons for cardiogenic shock. Number 1 is tension pneumothorax. Number 2, cardiac tamponade. And what is the third cause in trauma? Everybody can tell me tension pneumothorax and cardiac tamponade. The third reason for cardiogenic shock that they occasionally ask you a question about is what? Volume depletion is not cardiogenic. That is hypovolemic shock. Ruptured vessel like aorta, it will lead to cardiogenic shock from cardiac tamponade. It bleeds in the pericardial sac and cause tamponade. Cor pulmonale is chronic, not acute. Sorry? Diffusion, effusion? No. I don't get an answer. The third cause is air embolism. These are the 3 causes and 3 presentations, 3 different treatments, which are immediately life-threatening within a matter of few minutes. So you got to recognize them, and tension pneumothorax is simple. Absence of breath sounds with deviation of the mediastinum to the opposite side. Easy. All right? You insert the needle, then you insert the chest tube. Cardiac tamponade is described classically for the boards as a triad of Beck. So it's Beck's triad. What is that? Profound hypotension, raised JVP, and muffled heart sounds. Those are the three causes, those are the three factors for cardiogenic shock, the Beck's triad: hypotension, raised JVP, and muffled heart sounds. What is the next appropriate step in the management of the patient who is having a cardiogenic shock from cardiac tamponade with Beck's triad diagnosed? Number 1, pericardiocentesis. Number 2, thoracotomy. Number 3, insertion of chest tube in the right or in the left pleural space. And number 4, IV fluid therapy. Pericardiocentesis. Absolutely. A wide cannula was inserted into the pericardial space and no blood was aspirated. Patient is profoundly hypotensive. Next appropriate step in the management of this patient's condition. Number 1, left thoracotomy and evacuation of hematoma from the pericardial space. Number 2, patient should have a transesophageal echo and echo-guided pericardiocentesis. Number 3, a CT scan of the chest should be obtained to identify the cause of refractory profound hypotension. Number 4, patient should be taken to the OR for an immediate laparotomy to rule out intra-abdominal bleed. Echo-guided. Echocardiogram guided pericardiocentesis. By the time you achieve it, the patient is already left you. It's gone. You won't have time. Thoracotomy, guys. Think like surgeons. You are being given a trauma patient. Get out from the cocoon of the medical thinking. There's no time for elaborate philosophical thinking out here. The patient is going to leave this world in a matter of few minutes. It's the battle between you and the angel of death. Pericardial vein road takes a lot of time. Now you have a patient who's going to code any moment. You have to get in and evacuate the clot. And in about 40% of the pericardial effusions where the bleeding has accumulated in the pericardial space causing tamponade, it's clotted off. That's why your pericardiocentesis did not work. That's why your window may fail too. And it takes about half an hour to get a window and 5 minutes to get into the heart with a left anterior thoracotomy. This patient is going to code in the next 2 or 3 minutes. This patient will die. There's no time to waste. There's no time to think. There's only time to act. Okay? So pick up thoracotomy in a patient where your initial plan in relieving tamponade fails. The next step is pericardial. The next step is thoracotomy. Another case scenario. Patient came in with a stab wound with an ice pick injury to the chest, just like this guy. You ordered a central venous line insertion by your junior resident. As the patient was getting central venous line inserted, he suddenly collapsed and became hypotensive. What is the next appropriate step in the management of this patient's condition? Number 1, remove the central line. Number 2, put the patient head down with right shoulder up. Number 3, immediate thoracotomy. Number 4, patient should get a chest X-ray to identify the cause of his deteriorating hemodynamic status. Head down, right shoulder up. Diagnosis is air embolism. What are the other scenes for the board where air embolism can come as a hypotensive patient, sudden deterioration, profound degree of hypotension in the trauma? They're all penetrating injuries. Injury to the neck, when you have a jugular vein open to the air, you can get air embolism in those cases. So penetrating trauma to the neck can bring about hypotension from cardiogenic shock due to air embolism. Be careful about that one. Inserting a line as the case we discussed earlier on. Third case scenario that they can give you is stab wound or gunshot wound to the chest, when you have pulmonary artery and the alveoli exposed to each other, with air being sucked from one compartment to the other, which means air from the alveoli migrating into the pulmonary artery and going into the left atrium. All these are examples of air embolism. Be aware, penetrating trauma to the chest or neck or putting an IV line into the neck can all be affiliated with sudden hemodynamic deterioration. Think about air embolism. The first thing you will do is a head down tilt, right shoulder up, and if the hemodynamic status doesn't reestablish, then what would you do next? Again, think about you and the angel of death. You don't have a lot of time. Patient is going to die. So you don't have time to think. You have time to act only. Thoracotomy, guys. All cardiogenic shock that is not relieved immediately needs a thoracotomy in the emergency room as a general rule. Think like a surgeon. Okay? That's why surgery is difficult. Because it's manual labor. All the time, getting things done. Okay, we are going to move on. Next case scenario. Chief complaint. This wound on my foot is getting worse. History and physical. A 73-year-old woman who is in the hospital for the management of her diabetes has a worsening foot ulcer. She has had hypertension and adult onset diabetes for 20 years. Over the last few weeks, an ulceration has developed on the ball of her right foot, which has grown to the size of a nickel. There is a small amount of drainage that not changed much since she noticed it. She denies any pain in her calves or feet on either side. She wears regular shoes most of the time. She denies any trauma to the area. Her regular medications are insulin and beta blocker. She is a well-appearing female in no apparent distress. She is afebrile with stable vital signs. Heart and lung examinations are normal. Her abdomen is soft and non-tender with no palpable masses. Examination of the lower extremities show that the arterial pulses are intact and strong bilaterally at the femoral, popliteal, and both posterior tibial and dorsalis pedis. On the ventral surface of her right foot, there is a 1 by 2 centimeter ulcer at the base of the big toe. There is a small amount of drainage. Probing the ulcer with a cotton-tipped swab demonstrates extension of the ulcer with a tract into the metatarsophalangeal joint space. There is also a significant callus around the ulcer. There is minimal edema of the foot, and she has decreased sensation to pinprick bilaterally. Classical case of a diabetic foot. Now, when we talk about diabetic feet, we have to think about diabetes causing ulcers in two ways: neuropathy and vasculopathy. Neuropathy starts the process, and vasculopathy promotes, continues, and progresses the process. These are the two basic principles in diabetic feet with ulcers. Now, what kind of neuropathy diabetics have? Motor, sensory, or both? Sense. I hear a lot of sensory. Sense. Sensory neuropathy is surely there, but there's motor neuropathy too. What happens to the joints of diabetics? What happens to the joints of diabetics? Charcot's joints. What are Charcot's joints? patient gets distortion of the joints because the muscles which are supplying, the nerves which are supplying the muscles around the joints are altered. Those nerves are altered. So the tone of the muscles across the joints is altered. Our muscles are responsible for keeping our joints in anatomical position. When these nerves are damaged, these muscles lose their tone and the joints begin to get deformed. And once the joints get deformed, they are Charcot's joints. And they create a pressure area over the joints. So you see a hammer toe is a classical example. Hammer toe, these are rather delicate toes, but nevertheless. Hammer toes is a classical example. A hammer toe is a classical example of a Charcot's joint seen in diabetics. If this guy keeps wearing the shoes he's used to wearing, what's going to happen? The area of metatarsophalangeal joint has become a pressure area in the foot. And the joints here are also crooked. And what happens is the pressure areas will develop all around wherever there is protrusion of the bone through the skin. So if you have metatarsophalangeal deformity, the pressure is going to be shifted right at this spot. And this is the classical spot where you develop an ulcer, foot ulcer in a diabetic. And the initiation is primarily because of neuropathy. The second thing that happens is, even though they have developed an ulcer, they don't feel they have got any lesion because they have no sensation. They don't have the gift of pain. You know about the gift of pain? We protect ourselves from this gift of pain. If we don't have the pain sensation, then we lose that gift and we get injured without ever knowing that we are getting injured. There's a British professor who in India served the leprosy victims. And when he retired in Seattle, he wrote a book, The Gift That No One Wants, The Gift of Pain. And that's what happens. When you lose pain sensations, you damage yourself without knowing you're damaging yourself. That's why it is a gift. And when you get the ulcers are not noticed. You don't feel anything abnormal. You keep wearing the same shoes till the ulcer gets deeper and deeper and deeper. And finally erodes into the area of least vascularity. And what is the area where there's absolutely no vascularity underneath this ulcer? Is the joint space, the cartilage. There is no vessels there. The bacteria multiply and divide secondarily to the ulceration in the area of least vascular resistance, which means that the joint space gets secondarily infected. Once the joint is exposed under the ulcer, it's osteomyelitis, and you will have to treat this patient by disarticulating the big toe and removing the cartilage from the head of the metatarsal bone and exposing it to heal by secondary intention. Even though my patient had bounding pulses all the way down, why couldn't I have gotten this to heal? What do you think happens in diabetics? Do they really have? They don't have. They may have macro, but they have microangiopathy before they develop macroangiopathy. So although the big vessels are palpable, the capillary circulation is poor to the tissues. And so it's a combination of microangiopathy and neuropathy that leads to ulcers, which will lead to amputation of the toes. If you try and preserve this toe, what's going to happen? Would you be able to drain the infection effectively? No. If the infection is not drained effectively in a diabetic, then where would it travel? Well, it's going to travel on the dorsum of the foot along the tendons. Tendons and their sheets are also avascular. So the bacteria are going to have a great time multiplying in the areas of least resistance in the body of an individual who is already immunocompromised, whose neutrophils don't work well, whose blood supply at best is poor. So these bacteria rapidly multiply and travel along the sheets, synovial sheets of the tendons of the foot. And then the next step you're going to see is a poorly drained and inadequately drained ulcer in the foot causing infection that is ascending upward. You will feel the redness. You will see the erythema. you will feel the induration in the dorsum, edema and swelling of the foot, followed by crepitation. Now the gas is forming. And then the infection is going to develop rapidly and go upward. And the patient will develop necrosis of the foot, then of the leg, and you may end up losing the leg if you try and save the toe. So in diabetics, it's a true emergency, aggressive treatment by taking this toe off, debriding the cartilage, and letting it heal by granulation tissue. Secondary intention healing. And this question is frequently asked in step 3. Moving swiftly on to the next case scenario. Presenting complaint, a pulsatile abdominal mass. This is a case of a 68-year-old man with hypertension who comes to the clinic because of a pulsatile abdominal mass. The patient denies any abdominal or back pain in his leg while walking, or shortness of breath or chest pain. His current medications include a calcium channel blocker and a beta blocker. He has a myocardial infarction 20 years earlier. He appears well and is in no apparent distress. His blood pressure is 125 by 185. That's not possible, isn't it? It's a misprint. 125 by 105. His is equal in both arms, and pulse is about 68 a minute. Heart and lung examinations are within normal limits. His abdomen is soft and non-tender. There is a 6 centimeter pulsatile mass palpable in his mid-abdomen. Rectal is negative for stools and is negative for masses. The prostate is large and rubary with no palpable masses. Examination of extremities shows no evidence of ischemic changes. Femoral, popliteal, and pedal pulses are strong and equal. When you get pulsatile abdominal mass, there are only two things: abdominal aortic aneurysm and abdominal aortic aneurysm and abdominal aortic aneurysm and abdominal aortic aneurysm. There's hardly anything that mimics this than a proper abdominal aortic aneurysm. Very rarely you would find a tumor sitting above the aorta and transmitting the pulses. But for board, it is AAA unless and until proved otherwise. So I presented this man to you in the clinic. The next appropriate step in the management of this patient's condition is, number 1, reassure the patient that this is nothing to worry about and send him home with the advice to stop smoking. 2, patient should be admitted immediately to the hospital for emergent laparotomy and repair of the aneurysm. 3, patient should get an ultrasound of the abdomen as the initial diagnostic step. 4, patient should be admitted for a CT scan of the abdomen, chest, and pelvis. And 5th, patient should be advised to go on beta blockers, as this will reduce the incidence of further complications from this entity. The imaging study initial will be to do an ultrasound to confirm your clinical suspicion. An ultrasound was done which confirms that the aneurysm is 6 centimeters in size. What is the appropriate advice you're going to tell your patient now? Number 1, tell your patient that a 6 centimeter abdominal aortic aneurysm is a dire surgical emergency and he needs to go to the emergency room immediately. 2, advise the patient that the risk of rupture at 6 centimeters is high and you would recommend elective repair. 3, patient should be advised to go home, stop smoking, beta blockers, and follow up in 6 months. 4, patient should be advised to get the CT scan next time if the pain recurs. Advise your patient that the chances of rupture are high if the aneurysm is more than 6 centimeters and you would recommend elective repair. That's the right response. All right. Now, the critical thing to understand about abdominal aortic aneurysm is to draw a graph. This is not very... We need a red. Red really gets the notice. Okay. Now what you're basically doing is you're graphing the size of the aneurysm, size in centimeters, to risk of rupture. And from 1, 2, 3, 4, come 5, it goes up like that. So there is a precipitous rise in the risk of rupture the moment the aneurysm crosses 5 centimeters. So any aneurysm 5 or above should be repaired electively. That's number one indication for surgical repair. Any aneurysm that is symptomatic should be repaired urgently. Any aneurysm that is ruptured should be repaired emergently. And any aneurysm that is growing faster than 0.5 centimeters a year should be offered surgical repair because that is more than normal rate of growth. Abdominal aortic aneurysm is predominantly a male disease seen in hypertensive old women, old men. Clustering is seen in the families, so it is familial. It is genetic. We don't know exactly what causes it. Now, before you operate on the patient with abdominal aortic aneurysm, the case in point that we discussed, what is the next investigation after ultrasound to work up the anatomy of the abdominal aortic aneurysm? Number 1, an aortogram. Number 2, a CT scan. Number 3, an MRI angio. And number 4 is a duplex scan. Aortogram? No. MRI? Now, CT is the only one left which is reasonable. CT scan is your right test. After ultrasound, the definitive anatomy is documented preoperatively on doing a CT scan of the abdomen. What a surgeon is interested in looking is whether this aneurysm is suprarenal or not. 85-90% of the aneurysms are infrarenal. What you want to see is the proximal limit of the neck of the aneurysm. Majority of the aneurysms are below the renal artery. This is the diaphragm. So that's the renal artery. That's your aneurysmal neck. So 90% of all your aneurysm are infrarenal. If the aneurysm is suprarenal, then you have to evaluate how high is it going. Is it going all the way into chest? And the operative treatment for that is entirely different. It requires a bypass before you can operate on those aneurysms. Once you have defined that the anatomy is infrarenal, then the approach is various. You can go retroperitoneally or transperitoneally, but the main thing is to get the aneurysm dissected off and put a graft in the middle. It's a graft that goes straight graft that goes down like that, anastomosed here, anastomosed here, and this is basically closed over. Once you open the sac, you close the sac. The sac is not excised, it is simply closed over the graft. A patient was known to have a 6 centimeter abdominal aortic aneurysm, but he refused surgery. He presented one day in the emergency room. The paramedics brought him because he fainted at home. He presented with blood pressure of 90 by 60. He is usually hypertensive at 180 by 100. His blood pressure on arrival in the ER is 90 by 60. Pulse rate is 120. He is appearing agitated and restless. His abdomen is distended with a pulsatile mass. Bilateral femoral pulses are palpable but are unequal. The next appropriate step in the management of this patient's condition is, number 1, patient should have a repeat CT scan of the abdomen to identify the cause of his deterioration. Number 2, patient should be taken to the OR for exploration immediately. Number 3, patient should be resuscitated in the ER to a blood pressure of 120 systolic or more before deciding upon exploration. Number 4, an ultrasound of the abdomen should be repeated to confirm the diagnosis of sudden deterioration of his abdominal condition. A patient who is known to have a large aortic aneurysm presents with shock and abdominal distension and unequal femoral pulses, has nothing else but a ruptured aneurysm. A ruptured aneurysm should not be resuscitated like any other injury and should be explored in the OR immediately. Why would you hesitate from resuscitating and bringing his blood pressure up? You are very categorical about not resuscitating him. I appreciate that, but why? What's going on in your mind for not resuscitating a ruptured aneurysm? Coagulopathy, bleeding. Once you resuscitate the patient, he will bleed intraperitoneally. Most of the aneurysms rupture and leak while they are in the retroperitoneum. The leak is contained by the intact retroperitoneum. So the aneurysm bleeds, patient gets a syncopal attack, he drops to the floor, his wife calls 911, but by the time the 911 response comes, patient stabilizes because the bleeding stops because of the retroperitoneal tamponade. The retroperitoneum is intact and it tamponades it. Having a hypotensive episode and keeping a systolic below 100 is protective. It has allowed this patient to live through this catastrophe to arrive in the hospital to be saved by you. If you give him fluids, if you give him blood in the ER to bring his blood pressure up, you are going to burst through the tamponade and the bleeding will be free in the peritoneal cavity. So do not resuscitate these patients. They need to be rushed to the OR for exploration. The patient was taken to the OR and explored. Post-exploration, the patient was admitted to ICU and was doing fine till the third day post-operatively when the nurse called you and said, this patient is complaining of abdominal pain and this morning became tachycardic, spiked a fever to 102 and had a foul-smelling bloody diarrhea. What is the next appropriate step in the management of this patient's condition? Number one, patient should be taken to the operating room immediately for exploration to rule out intra-abdominal collections. Number two, patient should have a bedside sigmoidoscopy. Number three, patient should have a stool for patient should have a stool culture for C. diff colitis. And number four, patient should have a CT scan of the abdomen to identify the cause of this patient's condition. CT scan? Huh? No. He's got fever, he's got leukocytosis. Leaking anastomosis will be blood and hemorrhage and shock and abdominal distension. I don't give you any of those. Yeah. What happens is, when you are repairing an aneurysm that is leaking, you have one artery that is coming out from in front of the aneurysm. That's IMA, inferior mesenteric artery. And in about 30% of the cases, this is the sole supply to the sigmoid colon. The rest of the time, there's collaterals that are coming to sigmoid colon. In 30% of the cases, this is the only one. So when you ligate it, the blood supply, the sole blood supply to the sigmoid colon is gone. 2 or 3 days later, you will find evidence of ischemia, necrosis, bleeding, and foul-smelling diarrhea. Patient will get leukocytosis, abdominal pain. That's classical. The main differential here is whether this is C. diff colitis, pseudomembranous colitis, or ischemic colitis. Bedside sigmoidoscopy will make a difference between both the conditions and guide you into the right path. If it is pseudomembranous colitis, dirty gray membrane will be noticed in the sigmoid colon. Patient needs to be treated by metronidazole. If the patient has a grayish, fluffy, bloody, mucus membrane with multiple areas of punctate hemorrhages, this is ischemic colitis and patient needs to go to the OR and explored for resection of the ischemic valve. Those questions are asked. So be aware of those. Next case. The patient states that I have blood coming out from my nipple. This is a case of a 36-year-old woman who comes to the clinic complaining of intermittent bloody nipple discharge of the right breast over the last 2 months. It is spontaneous in nature without any relation to her menses. She is not pregnant. She does not take... Have you found it? Where is it? Page 67? Please open page 67. So it's a case of a 36-year-old woman who comes to the clinic complaining of intermittent bloody discharge from the nipple of the right breast over the last 2 months. It is spontaneous in nature without any relation to her menses. She is not pregnant. She does not take any medications or use birth control pills. She denies any associated breast mass with the discharge. She denies trauma. In general, she is a well-appearing female in no distress with stable vital signs. Physical examination shows that both breasts are symmetrical with no evidence of nipple retraction. There is no axillary adenopathy. Both nipples appear normal with no evidence of any lesion. At 2 o'clock position of the right nipple, a small pea-sized nodule is palpable and a small amount of serosanguinous discharge can be expressed when palpating this region. The left nipple has no palpable masses. The remaining breast tissue is without discrete masses bilaterally. The remainder of the examination is normal. What is the most common cause of serosanguinous or bloody discharge from the nipple of a breast? Intraductal papilloma. Intraductal papilloma is malignant or benign condition. So why do we worry so much about blood from the nipple? Because in the differential diagnosis, right on top is cancer of the breast. As a general principle, conditions associated with cancer of the breast or cancer of any part of the body are cancers unless and until proved otherwise. If I take 100 breast nipples with bloody discharges, how many of them will have intraductal papilloma and how many will have an underlying malignancy as a cause? What is the proportion? Which one is more common? How much? Give me the number. Give me the figure. 90% are intraductal papillomas. It's only 10% that have malignancy. But 10% is too much. So every single breast bloody discharge is malignant unless and until proved otherwise. Gastric ulcers, same principle. Okay? They are cancers unless and until proved otherwise. Thyroid nodules that are cold are malignant unless and until proved otherwise. Independent of age. Independent of age. Absolutely. Okay? But in step 3, the classical presentation will be an appropriate age group. Will be an appropriate age group. The most common breast lumps under the age of 30 are, the most common breast lumps between 30 and 50 are fibrocystic disease. The most common breast lumps after the age of 50 are cancers. That's the general principle. However, when you have somebody who presents with a suspicion of a history of breast cancer, irrespective of age, you have to rule it out. If I give you a case scenario of a 25-year-old female who feels a discrete 2-centimeter mass in the upper outer quadrant of her right breast, she says that the mass has been present for the past few months and it increases and decreases in relation to her menstruation. What is the most likely cause of this breast mass? What is the next appropriate step in the management of a patient with a breast mass that's palpable clinically? Ultrasound, mammogram, fine needle aspiration cytology, or a repeat follow-up in 2 months? For the purpose of step 3, you will do a fine needle aspiration cytology on 2 lumps the moment you put an eye on them. One is breast, the other one is solitary thyroid nodule. In real life, more and more breast lumps are being investigated by radiological screening first. And I'm using the word of radiological screening because not all breasts need or can have mammograms. Breasts under the age of 30, mammograms are not useful because the breasts are radiodense and the yield from mammography is poor. Young breasts under the age of 30, the investigation, the radiological surveillance is by sonogram. The breast over the age of 30, you do mammograms. And by and large, in today's practice, we are doing radiological survey of the breast before we do FNAC. But for the boards, we'll do FNAC first, and then mammograms or sonograms respectively. Okay? Now, the patient had a fine needle aspiration cytology of a firm, hard, rubbery breast lump, and that came back as benign. Most likely cause is a fibroadenoma. What would be your advice to your patient after these tests? Number one, advise your patient that the fibroadenoma is a benign condition. However, you would recommend removal because it will not resolve on its own. Number two, reassure the patient that this is guaranteed to be a benign lump and discharge from follow-up. Number three, advise the patient to come back only if the lump begins to increase in size. Number four, patient should be advised for annual mammography after she attains the age of 30 on. There is no way in the world you can guarantee this lump to be benign on cytology, on radiological evaluation. And majority of the fibroadenomas do not resolve, they persist. So your advice will be to have it removed. And you will only advise it. You will not, you make recommendation, you not throw an order to your patient. Okay? Alright. When you have a patient like bloody discharge from the nipple, what is the next appropriate investigation in this case scenario that is in discussion? It's a 35-year-old female with bloody discharge from the nipple. Next appropriate test is, number one, is do a sonogram. Number two, do a mammogram first. Number three, do a ductogram. And number four, patient should be taken to OR for excision of the culprit duct. Mammogram is your right answer. Why do you want to do mammogram? Would you see anything on a mammogram concerning this breast? You can see calcification. You're doing a mammogram because you want to rule out underlying malignancy. You don't feel any lumps, but you never know whether there's an underlying malignancy. And mammogram can actually pick up breast cancers that are not palpable in 90% of the cases. On the contrary, there are 10% of breast cancers that cannot be picked up by mammograms too. So it's a combination of three tests, the triple tests for diagnosis of breast cancer: palpation, mammography, and cytology. Remember that always. Palpation, mammography, and cytology, the triple test for confirming a breast cancer before you operate. Every single breast cancer should have all these three tests done in that order. Okay? Now, a mammogram was done and it did not reveal any features consistent with malignancy. What are the features consistent with malignancy? Number one, macroscopic calcification. Number two, popcorn calcification. Number three, microscopic calcifications present diffusely throughout the breast. And number four, discrete clusters of microcalcification. What are the other features of malignancy on mammogram apart from discrete clusters of microcalcification? Architectural distortion and retraction of the overlying skin or nipple. So there are three features on mammography that you should know at least. Microcalcification, which is discrete. Number two, architectural distortion. And number three, retraction of the overlying tissue, particularly skin or the nipple. Those are the three that I would like you to remember at least. All right. Now, the mammogram was negative. Are you going to proceed with your further tests here, or are you going to leave this patient alone? Mammogram, although reassuring, does not exclude malignancy. We know that 10% of the cancers are missed by mammography. So you have to excise the duct. Excision of the duct is the right answer. Now, as a general rule, what do you know about breast cancers? There are two types of breast cancers, those that are clinically palpable and those that are only radiologically evident on mammograms. So it's very important for you to have the concept that there are cancers that can be felt and there are cancers that cannot be felt. That's rule number one. Rule number two. There are basically two types of breast cancers. Infiltrating breast cancers and in situ breast cancers. Infiltrating breast cancers are those that have their cells have penetrated the basement membrane, and once they penetrate the basement membrane, they're all over. In situ are those where the basement membrane has not been penetrated. Rule number 3. Any infiltrating breast cancer is a systemic illness. It's all over the place. It's no more localized. Any in situ is localized to the breast only. Rule number 4. Treatment of infiltrating breast cancers is number 1, local, and number 2, systemic. Local treatment is afforded by surgery and radiotherapy, and systemic treatment is afforded by chemotherapy and hormonal therapy. Remember that always. These are the 4 principles of breast cancer before you can even attempt a question on this. Now, I'm going to give you a case scenario. A 45-year-old female with strong family history of breast cancer presents with a lump in the right upper quadrant of the breast, which was hard and non-tender. Fine needle aspiration cytology confirms it to be an infiltrating breast carcinoma. Lymph nodes on axillary examination were not palpable. Next appropriate step in the management of this patient's condition. Number 1, do a wide local excision followed by radiotherapy. Number 2, patient should get a mammogram followed by surgical treatment. Number 3, do a modified radical mastectomy. Number 4, patient should be followed up on mammography annually till the signs of axillary lymphadenopathy become obvious. First you do a mammogram and then you proceed with surgery, all right? Remember the 3 rules: palpation, mammography, and cytology. There are 3 ways to diagnose a breast cancer. And the reason you're doing it is you can argue, you can say, well, Dr. Faruqi, what about you're feeling the mass? You're palpating it. Why do you want to do a mammogram? Because you might not be able to palpate another cancer sitting in another quadrant of the breast that you may miss if you decide to do breast conservation therapy. For mastectomy, it's no big deal. For a conservation therapy, it is. Okay? So breast conservation therapy or mastectomy are comparable. True or false? MRM equals BCT. Is that true or false? It is true. Modified radical mastectomy and breast conservation therapy have equal outcomes. Modified radical mastectomy basically means you remove the breast and it's draining lymph nodes. Breast conservation therapy means you take a lump of the breast widely and axillary lymph node sampling and give radiotherapy to the remaining breast as a rule. So the advantage of BCT is that you keep the breast. The downside is you have to have it X-rayed, radiotherapy. The advantage of MRM is you don't need radiotherapy. Disadvantage is you lose the breast. Outcomes are same in both conditions. This is the local treatment, MRM or BCT. This is the local treatment of the breast. The systemic treatment is chemotherapy and hormonal therapy. As a general rule, all breast cancers get chemotherapy and hormonal therapy except 2 exceptions. Number 1, a postmenopausal woman with less than 1 centimeter breast mass with no lymph nodes palpable and no lymph nodes positive on pathology, and ER/PR receptor status positive. This patient does not require chemotherapy. Short of this, every other breast cancer will require chemotherapy. You got it? You didn't get it? Okay, I'm going to write it. All but this require chemotherapy. Post-menopausal, less than or equal to 1 centimeter breast cancer, lymph node negative, ER/PR receptor positive. You are going to treat her cancer by MRM versus BCT, followed by tamoxifen only. You don't need to give her chemotherapy. That's the exception to not giving chemotherapy. Everybody else gets it. There's an exception to hormonal therapy. All get hormonal therapy except one exception. Premenopausal, ER/PR negative. All women get hormonal therapy except premenopausal ER/PR negative. I'm simplifying it. Books are so complicated. This is the most simplified management protocol I can give. I fear it's oversimplified at times because there are so many gray zones, and I'm not about to discuss them at this level. Okay? So that's the general management. Remember, the management is number 1, local, number 2, systemic. Okay? And you need the exceptions to the rules for chemotherapy, exceptions to the rules of giving hormonal therapy. Otherwise, everybody else gets treatment for systemic disease. We presume that any cancer of the breast is a systemic illness, except for the in situ cancers, which is basically ductal carcinoma in situ. We take a 5 minutes break before we embark upon the last 90 minutes of our day. All right. Case scenario. 35-year-old female in the first trimester of pregnancy presents with a hard mass in the right upper quadrant of the breast. Patient states that she has a strong family history of breast cancer in the sense that her mother and her sister both were diagnosed with breast cancer at early ages. The next appropriate treatment in this patient's condition is, number 1, fine needle aspiration cytology, number 2, mammogram, number 3, sonogram, and number 4, the patient should be taken to OR for incisional biopsy. FNA first, mammogram follow. So do a physical exam, FNA, and a mammogram. The 3 things to diagnose a breast cancer. FNA and mammogram are consistent with the diagnosis of infiltrating ductal carcinoma of the breast. The next appropriate step in the management of this patient's condition is, number 1, BCT, number 2, MRM, number 3, pre-op chemotherapy, number 4, abortion. Why abortion? Huh? Why do you want abortion? Because the pregnancy caused the cancer and the cancer will get worse with pregnancy? No, those concepts are old. MRM is the right answer. Thank you, ma'am. Why do you choose MRM? Why not conservation? Because you cannot give radiotherapy to a woman who is pregnant. And you can't say, well, it's the first trimester, I will do your wide local excision, and after you've had your delivery, then I will give you radiotherapy. That's too late. So there's only one exception where you can do a wide local excision, that is BCT in pregnancy if you are in the last trimester in the later half. So after 4 weeks, once the baby is delivered, then you can subject the patient to radiotherapy. That's the only time. Otherwise, most of the pregnancy, right up to the 8th month, the treatment is MRM. Can you give chemotherapy to your patients who are pregnant? After 2nd trimester, you can. Thank you. So there are people in audience who know these facts. So those facts are tested, guys. Chemotherapy can be given during pregnancy after the first trimester. It's only the first trimester that you will not give chemotherapy, but second trimester on you can. So the treatment for breast cancer in pregnancy is MRM, followed by chemotherapy only in after the first trimester. It's a board question. Okay. Moving on. All right. Next case. I have a lump in my neck. That's the complaint. History is that of a 42-year-old woman who comes to the office with a lump in her anterior neck. The patient has been in her usual health when she notices a small lump at the base of her neck on the right side. It has not changed over the course of 1 month period. She denies any associated symptoms such as palpitations, hot flushes, or jitteriness. She denies any history of cancer in the head and neck area or any history of radiation to her neck. She denies any change in the voice or hoarseness. She does not smoke. In general, she appears healthy and is in no apparent distress. Examination shows a 2 centimeter soft, fixed nodule in the right lobe of the thyroid. There is no evidence of any other adenopathy in the neck. The remainder of her physical examination is unremarkable. The next appropriate step in confirming the diagnosis of this patient's condition is, number 1, a thyroid scan. Number 2, an ultrasound. Number 3, thyroid function tests. Number 4, fine needle aspiration cytology. FNAC is the right response. Always remember, whenever there is a solitary thyroid nodule in your boards, the right answer is, first of all, to attempt a cytology on it without any further investigations. Now, it's very important to understand the importance of solitary thyroid nodule. Solitary thyroid nodule basically implies malignancy unless and until proved otherwise. True or false? True. What is the percentage? If I give you 100 solitary thyroid nodules and you excise each one of them, how many of them will be cancers and how many of them will be benign? 90% of solitary thyroid nodules are basically adenomas, benign. It is those 10% for which you have to be careful and treat every single solitary thyroid nodule as if this was a cancer. Cytology is over 90% accurate in diagnosing cancers in the solitary thyroid nodule, particularly papillary, medullary, and anaplastic type. In fact, papillary carcinoma of the thyroid carries an accuracy rate of over 96 to 100%. It is very, very accurate. It has now become the gold standard for preoperative diagnosis of papillary carcinoma of the thyroid. That brings me to remind you about the pathology, that there are 4 types of thyroid cancers. The most common variant is papillary cancer of the thyroid. It is seen in young people and in their early adult life, and it is seen in very old. So there's a bimodal age distribution. The next common variety is follicular, which is seen between the age of 30s to 50s, and it is seen in about 30% of all solitary thyroid nodules. Then you see a rare variant is medullary carcinoma of the thyroid. It doesn't arise from the follicle, it arises from the parafollicular cells or C cells, and it secretes calcitonin. And calcitonin is the tumor marker for these thyroid nodules. The other important affiliation of medullary carcinoma of the thyroid is what? It is a component of multiple endocrine neoplasia syndrome, MEN1 and MEN2. Remember that. The 4th variant is anaplastic, which is seen over the age of 65. In terms of prognosis, papillary, 5-year survival, greater than 90%. Follicular, 5-year survival, about 70%. Medullary, 5-year survival, 40%. Anaplastic, 1-year survival, 0%. Very aggressive tumor. It goes around the trachea and asphyxiates its victim. They die from inability to breathe because it grows rapidly And some people think that this is a papillary carcinoma of the thyroid which got neglected and in the old age group degenerates to a very severe anaplastic type of a tumor. In papillary, medullary, and anaplastic cancers of the thyroid, FNAC is useful. It is the medullary carcinoma, it is the follicular carcinoma where FNAC is not very accurate. Because it is in this situation that you cannot cytologically differentiate between a follicular adenoma and follicular adenocarcinoma. The differentiation is based upon the architecture of the tumor. If the cells are invading the blood vessels, lymphatics, and rupturing the capsule, it is malignant, otherwise it isn't. So it's not the character of an individual cell that can diagnose the cancer. It is the nature of the architecture of the tumor. So be very careful about that. The patient was diagnosed with papillary carcinoma of the thyroid, which is 2 centimeters or more in size. The best or the optimum treatment is, number 1, to do lobectomy with hysterectomy. Number 2, to do subtotal thyroidectomy. And number 3, to do total thyroidectomy. And number 4, to do enucleation of the nodule only. What is the best answer? Subtotal? Why subtotal? Why do you think subtotal is good answer? You said it, you defend it. If you are concerned about the parathyroid gland safety, if you are concerned about the recurrent laryngeal nerve damage, what on earth are you doing in thyroid surgery? Give it to the professionals. It's not meant to be for those who are amateurs. That's why there are specializations within surgery. Okay? So if you're concerned, if your argument is, I don't want to damage the blood supply to parathyroids to cause hypoparathyroidism, fine. Give it to somebody who can preserve it, who knows what he's doing. If you think that my rate of recurrent laryngeal nerve damage is very high with total thyroidectomies, you shouldn't be doing thyroid cancer surgery. The best answer in the board is not for the amateurs to be taking references for these cases, is for giving it to professionals. Board considers treatment of his patients in ideal circumstances. And we do have that in this country. We have specialists who do thyroid surgery very well. They're everywhere, in every city, in every university. You shouldn't be doing it in the community if you're scared about blood supply to the parathyroids. Okay? So the best answer is total thyroidectomy. Remove the entire gland. And I have further arguments in my favor. I'm not just going to be dogmatic. I'm going to prove that my choice is the best choice. Now I'm going to tell you a principle of oncology. Whenever you see a cancer, the principles of oncology are, number 1, diagnosis of the cancer. Number 2, stage the tumor. And number 3, treatment of tumor depending upon the stage. Whether it's esophageal cancer, whether it's gastric cancer, whether it's colon cancer, whether it's pancreatic cancer. Right? You diagnose it, you stage it, and then you treat it. Thyroid cancer is an exception. First you diagnose it, then you treat it, after which, post-operatively, you stage the patient. How do you stage a thyroid cancer? Choices are ultrasound of the neck. 2, CT scan of head, neck, and chest. 3, bone scan. 4, radionuclear scan with iodine. Total body scan with iodine. Now, the philosophy is this. As long as you have the mother thyroid gland in the body or part thereof present in the body, you cannot stage the thyroid cancer metastasis accurately. Because cancer of the thyroid will not be able to compete with the mother gland, the normal gland, in concentrating iodine within themselves. So although if the cancer, for instance, hypothetically has spread to the bones or to the lungs or to the brain, and you do iodine scan after subtotal thyroidectomy, as recommended here, what's going to happen? All the iodine is going to be focused and concentrated in which part of the body? In the neck, where the parent gland is, and will not show the metastatic colonies of tumor. So there is inaccurate staging of the thyroid cancer. That's number one problem with doing partial or subtotal thyroidectomy. You cannot accurately stage the disease. The second problem with staging, with subtotal thyroidectomy is this. Most of the papillary cancers and follicular cancers are multifocal. If you do a partial thyroidectomy, you have left problems for future. There's a higher rate of local recurrence. And the third problem with partial thyroidectomy is that these patients are able to generate some degree of thyroxine production. So they're not grossly hypothyroid. But if you were to remove the entire gland, you will be guaranteed to supply these people thyroxine every single day of their life to suppress TSH. Now, is that good for cancer or is that bad for cancer? It's very good for cancer to suppress TSH because TSH stimulates cancer cells in the body. You want a guaranteed 100% suppression of TSH by providing exogenous thyroxine for the rest of the life of a patient with total thyroidectomy. You are achieving that function securely and surely. So there are three good reasons to do a total thyroidectomy. Now, when you scan the patient with radio-labeled iodine and you find that there are tumor deposits, how do you manage that patient? Number one, external beam radiation. Number two, brachytherapy. Number three, excision of nodules. Number four, radio-iodine ablation. That's right. The beauty of thyroid cancer, which is tested in the boards, is this, that this is the only tissue in the body that can concentrate iodine within themselves. If you give them radio-labeled iodine in a high dose, like 75 to 100 millicurie, they are going to concentrate this iodine within themselves because they are hungry for iodine ions. And what have they actually done by doing so? They have committed suicide. That's why we get such a good cure rate. 95% or more people with papillary cancer survive 5 years, which means they're cured. That's why we have excellent cure. So these principles, guys, are tested in the board over and over again every single year. Be aware of these, all right? A patient is a 40-year-old female with a solitary thyroid nodule. FNAC confirms medullary carcinoma of the thyroid. She says that her mother was diagnosed with another endocrine tumor in the abdomen. The next appropriate step in the management of this patient's condition is total thyroidectomy, number one. Number two, patient should have a CT scan of the abdomen with 24-hour urine collection for VMA. Number three, patient should have serum calcium levels and serum parathormone assays. And number four, patient should get system EB scan of the neck. Let me just throw everything out. Let me just try. You guys are getting a little bit slack here, so I want to just get you guys awake a little bit, a little bit of sympathomimetics, sympathostimulation, a little bit of heartbeat, a little bit of pale color, a little bit of nervousness on the faces, sleep to go away, get up and get awake and get alert. There is a question attacking your knowledge. It's a multiple endocrine neoplasia history. You have got 3 time bombs in this patient's body, not one. Number one is the cancer of the thyroid, medullary. Number two, this patient may have parathyroid adenoma with undiagnosed hyperparathyroidism. Number three, this patient may have a pheochromocytoma. Out of these 3 tumors, which one should you tackle first? Pheochromocytoma is the chemically most unstable tumor. What is the problem if you take the patient to the OR and do a thyroidectomy? What's going to happen to the patient if she really has a FIO hiding inside? The blood pressure will either go very high or will go very down. She will get severe hyper or hypotension, which will be refractory to any treatment. Why do they get hypotensive? I understand they get hypertensive because they have FIO, they have chemical liberation which cause vasoconstriction. Why do they become hypotensive? Why do people with pheochromocytomas, if not adequately prepared preoperatively, become hypotensive? Because there's increased tone, and if there's increased vascular tone, you give them anesthesia, you relax them, their tone is lost, and the volume that they have in their circulation is high or low. People with pheochromocytoma, are they euvolemic or hypovolemic? They're hypovolemic. They're walking around with low blood volumes because their sympathetic tone is so high that their intravascular volume is small. When their intravascular volume is small, the volume running within the blood vessels is small. And eventually what happens is, when you remove that focus, when you remove that stimulus, and you relax their smooth muscles of the blood vessels, the tone is lost and they get vasodilated. Once they get vasodilated, you have a patient basically in a hemorrhagic shock kind of a picture, hypovolemic with blood pressure down to the boots. So how do you prepare a patient who is diagnosed with pheochromocytoma? You give them phenoxybenzamine, which is an alpha blocker, and if the patient has history of palpitation and arrhythmias, then you give them beta blockers. Which one do you start first? Alpha blocker first. 2 to 3 weeks before surgery, start them on phenoxybenzamine. After about 2 weeks of phenoxybenzamine on the system, you start beta blockers. Not before, not with. If you give beta blockers before alpha blockers, what's going to happen? Patient will have reflex hypertension because the unopposed action of alpha receptors will cause severe vasoconstriction. Normally, a beta receptor stimulation causes vasoconstriction or vasodilation. Beta receptor stimulation by adrenaline causes vasoconstriction or vasodilation. Alpha 1 receptor stimulation by norepinephrine causes vasoconstriction or vasodilation. FIOs have both beta stimulation by APIs and alpha 1 stimulation by norepinephrine. You selectively block beta receptors. The epinephrine vasodilatory effect is completely gone. Unopposed, complete 100% norepinephrine rule in the body with alpha receptor stimulation causes severe, profound hypertension. You never start beta blockade first. Always first block the alpha receptors, then do the beta blockade. And the reason why you're doing it is to make the patient euvolemic. You don't need to admit the patients. Their usual physiology will readjust the blood circulation. So by the time they come, they're alpha blocked, they're beta blocked, they're euvolemic, then you operate. If intraoperatively their blood pressure fluctuates and goes up, then you give them phentylamine drip. Okay? That's the treatment and the protocols for VMA, and metanephrines are the two byproducts in the urine that you have to check for in the diagnosis. Pheochromocytomas, observe the rule of 10. 10% are bilateral. 10% are seen in children. 10% are familial. 10% are extra-adrenal. 10% are malignant. Rule of 10, you know that. You know that all, right? What is the most common extra-adrenal site of a pheochromocytoma? CT scan is usually done for an adrenal. You do a CT scan, VMA is high, and metanephrines are high in the urine. You're suspecting pheo, you do a CT scan, both adrenal glands are normal. What is the most common extra-adrenal site for pheo? What do you call that bifurcation? Give me the name. You didn't impress me that much, huh? That's why I need some epinephrine liberation, huh? Organ of Zucker-Kendall. It's a sympathetic tissue that sits right across at the bifurcation of the aorta, right here, just below the inferior mesenteric artery. This is the most common extraadrenal site of pheochromocytoma. And if you have that, CT scan will not pick it up. The test of choice is MIBG scan. The test of choice is MIBG scan for extraadrenal pheochromocytomas. So you check the pheochromocytoma first before you do a medullary carcinoma of the thyroid. And that has been asked. Okay, we are moving on, guys. What is MIBG? Don't ask me that, I've forgotten it. I don't remember the short form of it. It's a radionuclear study, which is basically focused on tissue that can concentrate epinephrine and convert it into norepinephrine. All right, moving swiftly on to the next case. This case is a patient who complains of I have hard time swallowing food. It's a case of a 65-year-old man who comes to the office complaining of dysphagia. The patient was in his usual state of health until approximately 1 month ago when he noticed difficulty in swallowing, especially solid food, although he does not seem to have any problems with liquids. He also notes a 10-pound weight loss in the last few weeks. He has a 50-pack a year smoking history and drinks 3 or 4 shots of vodka a night. He had an episode of pneumonia about 8 months ago. He's a thin man in no distress. There is some evidence of bitemporal wasting. Temperature is 37. Blood pressure is 125/80. There is no head and neck adenopathy. His lungs are clear to auscultation and cardiac exam is normal. His abdomen is soft with no palpable masses. Rectal examination shows GOAC positive stool and no palpable masses. Dysphagia, weight loss, male, elderly, smoker, alcohol abuser. What else do you want? What is the diagnosis? Cancer, cancer, cancer. Okay? All these are buzzwords telling you this is malignancy, guys. This is not achalasia. This is not esophageal stricture from reflux esophagitis. This is cancer. Okay? But dysphagia, it's very important for all of you to appreciate, is a symptom that encompasses number of disease processes. It's not only just seen in malignancy. It is seen in reflux with peptic strictures. It is seen with achalasia. And it is seen with cancer. So you got to know how to differentiate one entity from the other. The disease pattern, the clustering of symptoms, the age group, the sex, the age of presentation, the type of dysphagia. Is it starting off with solids or is it starting off with liquids? You know, those things are important. Now, if it's a case like this, a 28-year-old female presents to you with a history of difficulty in swallowing. She says that she has no problem swallowing the solids, but when she drinks liquid, it seems to fill her up. She has to sit up and wait for a while before the fluid can wash her food down. She says that she has belching and eructations which are rather foul-smelling, and her boyfriend has left her because he can't stand the bad breath. She has been losing weight because she can't maintain her nourishment. This has been a progressive case going on for several months. All right. What is the diagnosis? Achalasia. What is the next step in the workup of this patient's condition? Number 1, 24 hours pH monitoring. Number 2, manometry. Number 3, barium swallow. Number 4, upper GI endoscopy. Very good. Every single case of dysphagia, whether it is for cancer, whether it is for achalasia, or whether it's for peptic stricture, Starting point is a barium swallow for your boards. That's the first investigation, the road map. A barium swallow on this 25-year-old or 28 years old female was obtained, and it showed a sigmoid esophagus. With an air fluid level in it. That's a classical presentation of achalasia causing dysphagia. It's not a mechanical obstruction, it's a functional obstruction. The distal esophageal sphincter does not relax in response to the swallowing. It's also seen in South America in a disease called Chagas disease, which is secondary to destruction from the, what is the organism called? Trypanosoma, yeah, that's right. Okay. The gold standard for diagnosing achalasia is, number 1, pH monitoring, number 2, video esophagogram, number 3, upper GI endoscopy, number 4, manometry. Manometry is the gold standard to diagnose achalasia. Okay? Now we're not going to go into details. The treatment for achalasia is calcium channel blockers, pneumatic dilatations. If that fails, surgery, Heller's myotomy. Divide the muscle all the way down to the mucosa at the gastroesophageal junction. Heller's myotomy. Myotomy is the treatment of choice. If pneumatic dilatations fail, because pneumatic dilatations have a higher risk of recurrence compared to surgery. Don't work. Higher risk of perforation. You put a balloon, dilate it. You need atmospheric pressure inside, measured atmospheric pressure inside the distal esophagus. Right here, the balloon needs to go and get dilated to a certain atmospheric pressure. Bougies will not do that. Okay? Second case scenario. Patient is a 40-year-old female who is fat and 40. She says each time she stands up or stoops, she feels acid or bile coming into her mouth. She complains of retrosternal heartburn and occasional dysphagia. She says she has these symptoms for a long time, but of late, when she went to a steakhouse and she tried to swallow the steak, it got stuck right here in her chest. She gives no history of anemia, no history of weight loss, and looks rather well nourished otherwise. She doesn't smoke, she doesn't drink except for occasional wine, which she consumes when she's out on a steakhouse dinner. She has no lymphadenopathy. What is the diagnosis? Reflux esophagitis causing peptic stricture. Next appropriate step in the diagnostic workup: 24-hour pH monitoring, upper GI endoscopy, barium swallow, or a CT scan of the chest. No, barium swallow all the time. Dysphagia from achalasia, dysphagia from peptic stricture, dysphagia from cancer. Barium swallow, guys. I just told you that. I know it's a long day, but don't forget the principle. The first thing to do is to get the road map on every dysphagic. Why do you want a road map? Why not just go to endoscopy? Cut the chase, see it and biopsy it. Barium swallow will not help you with that. There's one more cause of dysphagia, particularly in the elderly, and it is for those that you want a road map. What is the fourth cause of dysphagia that the board tests you on? Thank you. Zenker's diverticulum. Bravo. What is Zenker's diverticulum? It is an Pulsion type of diverticulum. A Pulsion type of diverticulum that arises from the proximal cricopharyngeal area of the esophagus. If you look at the esophagus, the diverticulum arises proximally. And it's a Pulsion type of diverticulum, and the scope can go in here and perforate, because you may think that's the esophagus, and you push your scope in and it goes down into the wrong path into the diverticulum, and it can perforate the esophagus. Zenker's diverticulum is classically described for people over the age of 60, and they present with dysphagia. The reason why they become dysphagic is because when you have these patients to swallow food, the food goes and deposits in the diverticulum, and diverticulum distends and balloons like a balloon and compresses upon and impinges upon the upper esophagus. When they swallow, you can hear the gurgling sound. When they belch, you can smell the bad breath from the rotten food lying in the diverticulum for the past 2 weeks. When they are allowed to eat, they take a long time to finish their meals. This is from the fact that these patients have a muscle with a raphe and a weak point here right in the bottom of the raphe, and surrounded by the cricopharyngeus muscle, which is the superior constrictor of the esophagus. The esophagus arises here. The superior constrictor of the esophagus undergoes fibrosis, loses compliance that a normal muscle fiber has, replaced by fibrotic tissue. So it becomes a non-compliant sphincter, which results in high upper esophageal pressures, which leads to a Pulsion type of a diverticulum. Okay, diagnosis is based upon barium swallow. Treatment is, if it's less than 2 centimeters, then just do what? How do you treat a Zenker's? A Zenker is treated based upon its size. I want the answer. A Zenker is treated based upon the size. Less than 2, 2 to 7, greater than 7. If the Zenker is less than 2, doing a myotomy of the culprit muscle is all that is needed. Myotomy only. That will take care of the problem. If the Zenker is 2 to 7, myotomy is essential. That's the minimum you will do. Plus add diverticulopexy, which means you fix the diverticulum to the fascia at the back so that it doesn't displace and doesn't go any bigger. You stabilize it. If it is a giant diverticulum, you do a myotomy, of course. Myotomy is the least you are going to do, plus diverticulectomy. You remove the diverticulum. Why are you scared of doing a diverticulomy? You see the protocol there? You see the trend? You see the philosophy? We are trying to stay away from excision of the diverticulum. We do it only when it's absolutely essential, because there's a risk of leakage and infection. That's why. And it's not necessary. So why take that risk? Myotomy is the least you're going to do. Many people don't know that. They think diverticulectomy is the answer for Zenker's. Diverticulectomy is the answer for a large Zenker's. But any Zenker's requires myotomy. Every single Zenker's requires myotomy, not diverticulectomy. Okay? Okay. So, yes. For both. Patient with Zenker's have dysphagia for both. Now, this patient that I described to you with peptic strictures, you get an esophagogram and then you confirm what's the gold standard for diagnosing reflux esophagitis. 24 hours pH monitoring. The patients who have reflux esophagitis normally can be treated after investigating on PPIs, proton pump inhibitors. Those who develop complications of reflux disease like ulceration, strictures, or Barrett's change will benefit from surgery. And nowadays the standard surgery for reflux esophagitis is laparoscopic Nissen's funduplication. It is done laparoscopically. Nissen's funduplication. Okay. What is Barrett's esophagus? It is metaplasia of the distal third of the esophagus. What do you mean by metaplasia? Can you clinically define it for me? From squamous to columnar. So normally, what is the lining epithelium of the normal esophagus? What kind of squamous? Non-keratinized stratified squamous epithelium. What is the endoscopic color of a columnar of a stratified squamous normal epithelium of the esophagus? It's pale colored. It's pale colored. What is the color of a metaplastic columnar epithelium? It is bright pink or beefy red. So there's a sudden change from pale pink to bright pink or beefy red color. All right? It's the difference between this man's shirt and this man's t-shirt. So from pale pink to bright pink or beefy red in color. And once you have that, then there are two possibilities you can have in the columnar change. One is carditis. And the other one is Barrett's. So not all beefy red mucosa are Barrett's. Carditis can mimic Barrett's endoscopically. In order to confirm Barrett's esophagus, you need to biopsy it as well. If the tall columnar cells look like cells of the stomach, then it is carditis, not Barrett's. If the tall columnar cells look like cells of the intestinal tract of the small bowel, then it's Barrett's. The difference is in the population of goblet cells in the columnar change. If there are few goblet cells, it's carditis. If there is a humongous population of goblet cells, it is intestinal metaplasia, which is Barrett's. Why are we making such a hullabaloo about Barrett's esophagus? Barrett's esophagus predisposes to cancer. There's a 1% risk per year of malignant degeneration of Barrett's esophagus. How often do you see it? It's becoming increasingly appreciated as a disease. More and more people with reflux disease are coming for surveillance endoscopies, and it's becoming very, very common in specialized centers, which are referral centers for esophageal diseases. So the esophageal cancer from Barrett's is on the rise. It's becoming increasingly more diagnosed in an increasing diagnosis than it used to be in the past. And the Barrett's esophagus will degenerate into which type of cancer? Squamous cell or adenocarcinoma? Right. In the past, it was a disease of drinkers and smokers like the man in our question. And in those cases, you don't usually get adenocarcinoma. The common type was squamous cell carcinoma. Now we are seeing more and more esophageal cancers from Barrett's and adenocarcinoma type than we are squamous cell carcinomas. Okay? A patient with Barrett's esophagus gets an annual surveillance esophagoscopy. Biopsy reveals low-grade dysplasia. What is the treatment? Nothing. Just observe. Just observe. A patient with Barrett's esophagus gets an annual surveillance esophagoscopy. Biopsy reveals high-grade dysplasia. No infiltrative tumor is identified. How do you treat it? You do an esophagectomy. A procedure which in best of hands has a 6% mortality. High-grade dysplasia equals esophagectomy. True or false? You're not very confident. You're not very sure what I'm talking about. False. High-grade dysplasia is cancer? No. But what does it mean to you in the context of Barrett's esophagus? What is the meaning of high-grade dysplasia on colonic biopsy after 10 years of ulcerative colitis? Same principle. Do you know ulcerative colitis? Do you know it undergoes malignant degeneration after 10 or 15 years? It can. You know, if you do annual surveillance colonoscopy and ulcerative colitis and you find high-grade dysplasia in your colon, what are you going to do? Total proctocolectomy. Why? Because although it's not cancer itself, It's a marker of infiltrating cancer elsewhere that you have not been able to pick up. If you take out a colon of a patient with high-grade dysplasia and ulcerative colitis, about 85% of them will have infiltrating cancer already present. Likewise, if you take out an esophagus of a Barrett's esophagus with high-grade dysplasia, 80% of them will have infiltrating cancer. 20 will not. So for the sake of those 80, you get esophagectomy for all. It is as simple as that. It's a marker for presence of cancer already in that esophagus. That's the crucial point in understanding. Now, in a case in point that we had, we diversified ourselves into the discussion of dysphagia and discussed so many diseases in it. We discussed achalasia, we discussed Zenker's diverticulum, we discussed reflux esophagitis, we discussed Barrett's esophagus. But in the case in point, we have a 55-year-old male who is a smoker, who is a drinker, and who has dysphagia. Obviously, this man has got squamous, most likely a squamous cell carcinoma, because he has a 10-pound history of weight loss too. So the first step you do is a barium swallow study. The next step you do is an upper GI endoscopy, and then you biopsy the patient. Biopsy confirms squamous cell carcinoma. How would you stage esophageal cancer? As I said, every cancer, the protocol oncological surgical principle states, diagnose it first, stage it second, and treat it third. So diagnosis is done by pathology. You do biopsies of the tumor, and then you subject your patient for CT scan of the chest, abdomen. What you are basically looking at on CT scan is what? You're looking into the distant metastasis, which could be the hilar lymph nodes, mediastinal lymph nodes, lesions within the lung parenchyma, or liver nodules. If the patient does not have distant metastasis on CT scan, then the patient can be offered esophagectomy. But if the patient has evidence of distant metastasis, like hilar lymph nodes are enlarged, or liver nodules are found on CT scan, would you offer esophagectomy to this guy for palliation? You are offering colectomy for palliation, but not esophagectomy for palliation? You were right. Esophagectomy is not done for palliation. Esophagectomy is such a morbid procedure. It's much more morbid than doing a colectomy. So if you are doing an esophagectomy, or if you are doing a Whipple's operation for pancreatic cancer, you better be sure you've got a chance to cure your patient. Because the morbidity, the complications of esophagectomy are so high that it's balanced in favor of not doing it and giving it some other type of palliation to the patient. For instance, you can fulgurate the tumor by laser and rechannelize the patient's esophagus and treat the dysphagia. You can insert a stent to treat the dysphagia. You can nourish your patient by giving them a gastrostomy tube rather than taking out the esophagus. So there are ways to get around palliating these patients without necessarily doing an esophagectomy, whose morbidity and mortality are much higher than colon resection. So there is no role for palliative esophagectomies in cancers of the esophagus. Be very careful. All right? Okay, the next case is right upper quadrant pain. This is a case of a 64-year-old man who comes into your office complaining of epigastric and right upper quadrant pain. The patient was in his usual state of health until approximately 2 months ago, when he started noticing epigastric pain which radiated to the right quadrant and to the back, associated with 6 pounds weight loss. He also has noted darkening of his urine. Past medical history is significant for stable angina. On physical examination, he is a thin appearing male in no apparent distress. His sclera are mildly ecteric. Vital signs, afebrile. Blood pressure is 150/80. Head and neck examination is without adenopathy. Heart and lungs are clear, regular rate and rhythm. Abdomen is soft, non-tender and non-distended. There is a fullness in the right upper quadrant in the area of the gallbladder, rectal without masses, and goac negative. So you have a situation here where there's an elderly male who presents to you with right upper quadrant pain, palpable mass, weight loss, and what sounds like jaundice. Right? He's ecteric. He's got dark urine and clay-colored stools. So when you have a patient, then you look at the LFTs. And what you have to remember in LFTs are levels of the following: total bilirubin, direct bilirubin, alkaline phosphatase, transaminases, urinary bilirubin, and urobilinogen. And you classify your jaundice as prehepatic, hepatic, and post-hepatic. As surgeons, we are interested in post-hepatic or obstructive jaundice. And the grid is here. Prehepatic jaundice. Now these LFTs are tested all the time in the boards. You have to have a very clear idea about how to distinguish a prehepatic, hepatic, and a post-hepatic jaundice from each other. Prehepatic jaundice basically means that when God created liver asked the good Lord to sign a paper stating that He will only allow that much amount of bilirubin in the body for the liver to conjugate, and no more. It was also in the deal that if the body tends to make more than that set amount of bilirubin, it will be thrown back to the body. Liver will not be responsible for anything more than that set amount of bilirubin. So the function of liver is to conjugate bilirubin that is usually created by the body by a breakdown of RBCs in the spleen, in the liver, and in other tissues. So that broken down RBCs will liberate byproducts of hemoglobin. One of them is bilirubin. And bilirubin as such is not water soluble. So this bilirubin joins the albumin and gets transported to the liver, where it's taken up by the hepatocytes, where it gets conjugated to conjugated bilirubin. The conjugated bilirubin is water soluble. But by the time it arrives in the liver, it is excreted into the canaliculi, into the bile, into the gut, and gets excreted into the feces. Except for a small proportion of bilirubin which is acted upon by the gut into urobilinogen, which is absorbed from the gut back into the circulation and gets excreted in the kidneys. So normally what you see is that you have no bilirubin, a very small amount, less than 1 milligram of total bilirubin in the blood, and you have urobilinogen present in the urine. But normally, should you see bilirubin in the urine? No. Normally you shouldn't. Because you know that bilirubin, when it's broken down product, it is not water soluble, it should not be excreted by the kidneys. Okay? Normally bilirubin in the blood is not water soluble and should not be excreted by the kidney. So in prehepatic jaundice though, what is happening is that there's so much bilirubin being produced by the body, so much of RBC breakdown is taking place on a daily basis that liver's capacity to conjugate the bilirubin is overwhelmed. It does its job, it conjugates the bilirubin, and it excretes that bilirubin. But it only does so much as is contracted by Him and the Lord. And that bilirubin that it cannot conjugate throws it back to the general circulation. So the total bilirubin is high. Direct bilirubin is normal. Alkaline phosphatase is normal. Transaminases are normal. Is there bilirubin in the urine? In prehepatic jaundice, do you see bilirubin in the urine? Yes or no? Why? The bilirubin that the liver cannot conjugate is thrown back into the circulation. Is it water soluble? No. That's why it cannot be, because it is not conjugated by the liver. Liver refuses to accept it. So there will be no bilirubin in the urine. Will there be urobilinogen in the urine? Of course, there is no obstruction. Normal. In post-hepatic jaundice, the total bilirubin is elevated. Direct bilirubin is elevated. Alkaline phosphatase is elevated. Transaminases are mildly elevated. Is there going to be bilirubin in the urine? Yes, because there is obstruction, and conjugated bilirubin now pools up into the biliary canalicula and gets thrown back into the general circulation. So there will be urine bilirubin. What about urobilinogen? Yes and no, depending upon the degree of obstruction. If you see no urobilinogen in the face of obstructive jaundice, obstruction is complete. If you see urobilinogen in the face of obstructive jaundice, obstruction is partial. Okay? Plus or minus, depending upon the degree. In hepatic jaundice, a combination of pre-hepatic and post-hepatic jaundice is seen. Total bilirubin is elevated. Direct bilirubin is elevated. Alkaline phosphatase is elevated, but transaminase is very, 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 very high. Is there going to be bilirubin in the urine in hepatitis? Have you had hepatitis A? Have you seen a friend suffering from hepatitis? They have dark colored urine. Yes, bilirubin is present in the urine. Urobilinogen is present in the urine. That's the main difference between the three. What we are interested in is post-hepatic jaundice. Once they give you a scenario, look into the direct bilirubin. If it is predominantly direct bilirubinemia, like total bili of 12, direct bili of 8, you've got direct hyperbilirubinemia, alkaline phosphatase is elevated, transaminases are slightly high. That's a classical picture of obstructive jaundice from surgical causes. Now, extrahepatic biliary obstruction could be anywhere from the ampulla of water, cholangiocarcinoma, that means the common bile duct cancer, or cancer of the head of the pancreas, or cancer of the gallbladder, for instance. They will all give rise to obstructive jaundice. That's neoplastic causes of obstructive jaundice. Then there are non-neoplastic causes of obstructive jaundice, the most common of which is gallstones, choledocholithiasis. How would you differentiate one from the other? Give me one test that will tell you that. It was described. In the face of painless obstructive jaundice, if the gallbladder is palpable, the most likely cause of jaundice is a malignancy. If there is jaundice with no palpable gallbladder, it's most likely due to gallstones. This is Courvoisier's law, and it is based upon the knowledge that when you have gallstones, those gallstones cause fibrosis, inflammation, cicatrization, contracture of the gallbladder. Gallbladder with gallstones has chronic cholecystitis. They lose their compliance, they lose their plasticity, they lose their capability to distend in the face of obstruction. So when you have an obstruction distally in the common bile duct, in the case of gallstones, the back pressure in the biliary tree fails to distend the gallbladder, and gallbladder is not palpable. In contrast, if you have pancreatic head of the cancer pancreas, obstruction in the biliary tree, back pressure into the biliary tree, the entire biliary tree gets engorged from liver to biliary canaliculi to intrahepatic and extrahepatic ducts, and particularly the reservoir of the bile, the gallbladder. Here the gallbladder is free of disease. It does not have scars in its wall. It does not have chronic inflammation. Once the back pressure comes, it distends and distends and distends more because it's a chronic process and it becomes palpable. So when you have a palpable gallbladder, it's a normal gallbladder, which means the stone is not the cause, the cancer is. That's the main difference. The important test here to perform in a patient like this, who first came to the emergency room or to your office complaining of itching, pruritus, dark urine, clay-colored stool, yellow eyes, weight loss, smoking, alcohol, all these are risk factors for pancreatic cancer. The next appropriate step in the diagnosis of this patient's condition, CT scan of the abdomen, ERCP, PTC, ultrasound, KUB. It is ultrasound. Workup starts with an ultrasound. But the definite test to do is to do a CT scan of the abdomen after the ultrasound. Ultrasound will show you intra and extrahepatic common bile duct dilatation. It will show you distended gallbladder with no stones. But it may or may not show you pancreatic mass, because pancreas is deep-seated inside the loops of bowel. Gas prevents the sonographic rays to cross. CT scan is the gold standard for diagnosing the anatomy of the pancreas. If on CT scan you have a pancreatic mass, the treatment is what? You have a 5 centimeter mass in the head of the pancreas. The treatment is what? Do you need... CT scan doesn't show any other evidence of disease. Liver is free, hepatic lymph nodes are free, and there is no ascites. So it's a confined tumor of the head of the pancreas. Do you need pathology before you commit yourself for Whipple's? It's not necessary. No matter what you do, you have a mass there causing obstruction, you need to take it out. Diagnosing a head of the pancreas cancer pathologically, preoperatively is not easy. The standard is, once you diagnose on CT scan, there is mass in the head of the pancreas, is almost always considered a definitive diagnosis. There is one tumor marker test you can do, which can help, but if it's negative, it doesn't mean anything. That is CA19-9. That is classically elevated and CA head of the pancreas. If it is not elevated, you see a mass in the head of the pancreas, you still have to take it out. So it doesn't change your management. What changes your management is nothing but the presence of a mass on CT scan. Treatment is Whipple's. Well, this completes the management of the head of the pancreas cancer. And with this, it completes our discussion on step 3 cases. Thank you.